I'm Dr. Peter Apel. I'm a pediatric orthopedic surgeon and hand surgeon at Virginia Tech Carilion in Roanoke, Virginia, and I'm going to be talking about external fixators and extreme joint positioning for the management of soft tissue trauma in children. We have no conflicts of interest or disclosures. All patient images are used with patient and parental consent. And I want to give a special thanks to Anthony Capito and Trevor Owen, who are instrumental in our pediatric limb salvage team and some of these major pediatric cases that we've taken care of over the years. So, high energy soft tissue trauma in children can be very challenging. There's often tissue loss across multiple structures: skin, tendon, artery, nerve. Um, these wounds can require flaps and grafts to overcome deficits, nerve grafts, arterial grafts, and some of these complex reconstructions carry significant donor site morbidity, adding operative time, and local tissue may not be available. One thing with these major limb reconstructions is tension and pressure kills everything. Tension on nerves is a major detriment to their recovery. Pressure on flaps will lead to their demise. Tension on local skin flaps that have been brought over can lead to their failing. So, with these massive soft tissue swelling that occurs and the tissue loss that's usually existent, the overarching theme is that tension and pressure kills everything. And so the goal of using these external fixers is to decrease tension and in certain flap locations to keep the pressure off of the flaps. So external fixators are widely used in adult and pediatric skeletal trauma and deformity correction. But there's really very little literature that describes their use primarily when used for managing high energy soft tissue trauma. And there's certainly no literature on this technique in children. The basic concept behind external fixator placement and extreme joint positioning is that by positioning the joint at an extreme angle, you can decrease the tension on your wounds, your nerve repairs, sometimes eliminate the need for arterial grafting, hold it there for a period of time, and then do a gradual extension back to a functional position. So when we're talking about extreme positioning, we're talking about elbow flexion more than 90 degrees, knee flexion more than 90 degrees, uh, ankle plantar flexion more than 45 degrees. These positions that we wouldn't normally ever cast or fix somebody in because of the risk of developing permanent contracture. From a soft tissue management standpoint, the external fixator holds the position while the repair or the soft tissue or the flap heals. And then once that occurs, gradual correction can be used to return the joint to a functional position over the subsequent weeks, and then the external fixator can be removed. So why should pediatric orthopedic surgeons do this? Well, as a group, we're familiar with external fixator application in children and management, including gradual correction. We know that children tolerate extreme joint positioning and that they can recover range of motion of that joint, typically with time and activity, and that their skeletal growth is usually normal. And gradual correction will make it so that the soft tissues can then lengthen as they're healing. So to illustrate how we do this, I've got two cases. The first is this lawnmower injury to the posterior ankle. So this was a 7-year-old boy that sustained this lawnmower injury to the heel here. He had a posterior tibial artery injury, a calcaneus injury, Achilles tendon transection, and a substantial tissue loss that became evident over the repaired Achilles and calcaneus. So here he was when he first presented. You can see this large injury where the entire heel pad was taken off, going distally. Here's his radiographic injury. He's got a fracture slash laceration all the way through the calcaneus, but there's no subtalar joint involvement. He was taken the night that he first came in. We got the posterior tibial artery repaired, but unfortunately, the skin broke down. So on the left there, that's his 1-week follow-up in clinic. You can see we've got this tissue necrosis. On the right is when we took him back for debridement of this. And you can see that Achilles repair is widely exposed. So to manage this, my plastic surgery colleagues did an adipofascial turn down flap where the adipofascial tissue is elevated from the posterior leg and then flipped down over that exposed Achilles tendon repair. And then they covered it with a sheet graft of split thickness skin graft. But it required ankle positioning at about 50 degrees of plantar flexion to maintain the Achilles repair as well as detension the flap. So this is what the position looked like that we needed to be able to maintain. So to do that, our approach was to use a circular external fixator with a ring around the tibia and then a foot frame. These were connected through a hinge through the center of rotation of the ankle, and then an anterior strut that could be gradually shortened to bring that ankle up and out of plantar flexion. In addition, we built this kickstand off of the back, and the purpose of this kickstand was to make sure there was nothing whatsoever touching that flap. No bed sheets, no pillows, nothing. And that increases the likelihood that that flap will make it, because that flap um, is killed by pressure. If this foot sits on a pillow, that'll kill the flap. So in addition to the positioning of the ankle, the frame was able to provide protection to the soft tissue reconstruction. So for this kid, we held him at about 50 degrees of plantar flexion for 4 weeks, and then did gradual dorsiflexion through that strut over the next 4 weeks, and then ultimately removed the X-fix at 8 weeks. So here was his 6-month follow-up result. You can see the skin graft is fully incorporated. The flap did quite well, and he regained a full ankle plantar flexion and dorsiflexion. At his 3-year follow-up, he's obviously grown quite a bit. He demonstrates that he has excellent plantar flexion strength, is able to do a single limb heel rise. He's gone back to wakeboarding and all of his other activities. He's running around like a normal 10-year-old kid at this point. Radiographically, his calcaneus went on to union. So second injury, this is a patient who had a tractor injury to the popliteal fossa. So she was sitting in the bucket of a tractor, like I'm demonstrating here in my tractor, going through the woods of Virginia that we have here, and they struck a tree. And so that tree hit the anterior aspect of her knee, and she sustained this blunt guillotine injury to the left popliteal fossa. This was a substantial soft tissue injury. She had a vascular injury that did require interposition grafting. Her skeletal trauma was really minimal. I'll show that on the next slide. But her major injury after the vascular reconstruction was this soft tissue defect in her popliteal fossa. So here was her skeletal injury. She just has this little buccal fracture of the proximal tibia. So that night we did put a frame on her to detension her arterial reconstruction. We put her at about 20 degrees of flexion. We did her fasciotomies. So we took her back for management of her popliteal fossa wound. Unfortunately, she lost a lot of skin in that popliteal fossa. And when at the first look debridement, we had to bring her up to about 90 degrees just to get the skin closed in her popliteal fossa. Even with that, there was still some marginal skin at this point. When we took her back for her next debridement, there was more of that, and we had to flex her down to about 120 to get that closed in the back. The skin had demarcated at that point. We went ahead and resected it, closed the skin of the popliteal fossa, and then skin grafted her fasciotomy site. So this is what we were left with: the knee at about 110 degrees of flexion, and but the popliteal fossa is closed, and she didn't need a flap. But we needed to get her out gradually corrected. So she was then revised to a hinged frame with a strut, and the plan was for gradual extension. So this was her correction plan, 2 degrees per day. This was her strut length. So she was able to go home and do these at home. She did stall out. We weren't able to get her extended beyond about 40 degrees. So she was taken to the operating room for her frame removal, and we did a manipulation under anesthesia. Unfortunately, we gave her a little buccal fracture of her anterior distal femur, so this was treated in a cast. Ultimately, though, she did go on to unite that and heal up her pin sites. At 18 months, she regained 120 degrees in knee flexion and had about a residual 5-degree knee flexion contracture, healed her fasciotomy sites, healed her popliteal fossa, and healed all of her pin sites. By her 5-year follow-up, she had regained full knee extension, had full knee range of motion, had normal skeletal growth, and no leg length discrepancy. So the take-home points, external fixation and extreme joint positioning can reduce or eliminate the need for complex soft tissue nerve and arterial reconstruction. We can avoid the use of nerve grafts, we can avoid the use of flaps in some cases, and avoid the need for arterial reconstruction in some cases. Gradual correction over weeks restores a functional range of motion. I think that the limitations in the joint range of motion are typically driven by the underlying injury, that adding the external fixator doesn't add any additional joint sequelae in our experience. I think as pediatric orthopedic surgeons, we're uniquely positioned to deploy this technique given our familiarity with external fixation because of the routine use that we have with fracture care, as well as deformity corrections and lengthenings. And I would encourage you to consider this approach when local resources for complex soft tissue reconstruction are limited, or in cases with arterial or nerve repair where primary repair is preferable to grafting. Thank you. Appreciate your attention.